So is it visible?
Yes, sir.
Yes, sir.
So what are the features of fetal circulation system? Fetal circulation systems allow fetus to receive oxygenated blood and nutrients from the mother through the placenta. So placenta is the main interface between the mother and the fetus, and it comprises of blood vessels, the placenta, and there are two umbilical arteries and one umbilical vein. So which one carries the oxygenated blood and which one carries the deoxygenated blood in these two vessels? Even though you call arteries, do they have oxygenated blood or deoxygenated blood?
Deoxygenated blood.
Deoxygenated blood. They are actually they have to be remove the deoxygenated from the fetus, even though they are called umbilical arteries. And the umbilical vein is the one which is delivering the oxygenated blood to the mother fetus. So fetal circulation bypasses the lungs via a shunt known as ductus arteriosus. And the liver is bypassed via the ductus venosus, and the blood passes from the right atrium to the left atrium via the foramen ovale. So these are the three important communications in the fetal circulation which you have to remember. And the ventricular filling and contractility of the fetus is also very poor because the muscle mass is very small, it is not very compliant. So the filling and contractility both are reduced, and it gradually becomes normal after the child is born and starts growing at the age of 3 years. Then only it becomes like a normal ventricle. And fetal circulation undergoes rapid transition after birth because of the functioning of the lungs, which start their function at that particular time. So what changes take place in the circulation after birth? The pulmonary vascular resistance drops dramatically. Even after the first breath, the pulmonary vascular system, which was highly resistant to prevent any flow into the pulmonary capillaries in the intrauterine life, that resistance totally drops. It becomes a very, very low pressure circulation. That is happening in because of the response to oxygen. So in all these intrauterine life, as Dr. Kyle said, because there is no blood flowing, it is in always state of hypoxemia. So the hypoxemia caused the hypoxic pulmonary vasoconstrictor reflex in the intrauterine life, and that was the one which was keeping the preventing the blood flowing into the pulmonary capillary circulation. So once the alveolar, so the hypoxic pulmonary vasoconstriction responds to the alveolar oxygen tension, not the blood oxygen tension. Please remember that, because hypoxic pulmonary vasoconstriction is a short note question in the theory paper itself. So the main response to hypoxic pulmonary vasoconstriction is alveolar oxygen tension. So once the alveoli get filled with oxygen as the child breathes, this vasoconstriction is broken, and that is the reason for the drop in the pulmonary vascular resistance, which was very high in the intrauterine life. The factor which causes the increase in the systemic vascular resistance is the clamping of the umbilical cord, clamping both the arteries and veins. So all the blood starts flowing through the vascular system, helping the blood flow towards the lungs also through the right atrium and right ventricle. And the ductus arteriosus, which was always having a right to left shunt from the pulmonary into the aorta during intrauterine life, it gets reversed because the pressure in the system circulation becomes increased and the right-sided pressures drop. The flow reverses from left to right. And so the deoxygenated blood only mixes with the deoxygenated blood, and this happens within the first 10 minutes of life. But this communication, where there is a flow happening from the left to right, which will not cause any hypoxemia, because all the oxygenated blood only is going and mixing with the deoxygenated blood on the left side, right side. This will not cause any problem. Only thing, it may cause a little bit of overload on the right side of the heart. And this communication will, how long will it last? Will it close within the 10 minutes or will it continue to be there for some time? What is the time duration after which this ductus will completely close?
It will take 2 to 3 weeks for that
2 weeks, yeah.
communication.
So it may take 2 to 3 weeks. And in which condition you want this ductus to be patent and blood should flow from left to right? And what is the name for that condition?
Eisenmenger syndrome.
Eisenmenger syndrome. What is the congenital condition where there is a large amount of right-sided blood mixing with the left side and producing persistent
Pulmonary atresia.
pulmonary atresia? More common condition with 4 components.
Tetralogy of Fallot.
Tetralogy of Fallot. Okay, they are called cyanotic heart diseases. In cyanotic heart diseases, this communication has to remain open for a long time so that the pulmonary circulation will get some perfusion constantly. So the cyanotic heart diseases are classified into duct dependent and duct independent conditions. So that is another clinical importance of this particular communication between the pulmonary vein and the, pulmonary artery and the aorta. Okay. So if it remains open, so what are the things that can keep it open beyond that the time of, usually it start closing in a healthy child within the 72 hours. Okay, third day it starts closing. And initially it will be a functional closure and anatomical closure only takes about 2 to 3 weeks. So how to keep it open in case there is a right to left hand and you want some perfusion to continue in the lung or the pulmonary circulation? How can you, what are the methods to keep this circulation open and maintain the left to right hand instead of the right to left hand, which is happening in right only? Any drugs you can use? You can use indomethacin, which is a prostaglandin inhibitor. Okay, so normally we give indomethacin for the baby to maintain the patency of the left ductus arteriosus so that the pulmonary circulation will receive some amount of blood and the degree of hypoxemia can be mitigated by maintaining the perfusion from the aorta to the pulmonary artery. Okay, so that is another applied anatomy and importance in the ductus arteriosus. And in some patients, this may remain patent even as the child grows and becomes an older one. So what is that condition called?
Patent ductus arteriosus.
Patent ductus arteriosus, PDA. Okay, have you not heard of PDA? PDA is a condition where there is a left to right shunt and patient will not have any hypoxemia because only oxygenated blood is going. So if PDA is present, should it be closed by surgery or can it be allowed to remain like that? What will happen if you diagnose there is a PDA? How to diagnose clinically a PDA? What is the answer? Huh?
Murmur.
Murmur. What murmur? You are right. Auscultatory findings.
Missionary.
What is the name? It's a continuous or mill-wheel murmur. The name of the murmur is a continuous murmur because blood flows both during systole and diastole from the aorta into the pulmonary artery or left branch of the pulmonary artery mainly. Usually the communication will be the left branch of the pulmonary artery and it will flow both during the systole and diastole. So it is called a continuous flow murmur or a mill-wheel murmur. And why should it be operated? What is the indication to close this? What will happen? I have already told you what will happen. Even though hypoxemia is not happening, what will happen if the blood is constantly flowing from the aorta into the pulmonary circulation?
Increase the pulmonary artery.
It is causing a volume overload in the pulmonary circulation. So pulmonary vessels will start resisting that. Their pressure will go up. So pulmonary hypertension will happen, and right ventricle will find it difficult to pump the blood that it receives, and right ventricular failure will happen. So long-term effect will be right heart failure. So in order to prevent that, you have to close this communication. What are the methods of closing this communication?
Surgical closure.
Surgical closure, very good. So you can ligate. Is it a open heart surgery or a closed heart surgery?
The closed heart surgery.
The closed heart, you don't have to go into the open heart or a cardiopulmonary bypass, okay? Because it is outside the heart communication. You can do it in the beating heart itself in a closed heart procedure. So you have to just identify the communication, ligate it and divide it. That is the surgical procedure. The PDA ligation is the procedure which is done by open technique or by thoracoscopy nowadays, or gingioscopy. Any other interventional procedure by which you can close that without major surgery of thoracotomy and other problem?
Catheterization procedure, sir.
Yeah, you can do a device closure, just like you do the closure for ASD or VSD. That communication also you can close by device closure. Okay, so these are all some of the offshoot questions you can get if you get a question like this in the Viva. Okay, and the mechanism by which the ductus closes is by the smooth muscle in the ductus responds to oxygen by increasing calcium channel and causing constriction and ultimately the shunt closure. That is how the ductus closes. And the increase in systemic resistance raises the pressure in the left atrium and makes it higher than the right atrium, and this causes the foramen ovale closure. And how soon after birth the fetal circulation change to adult circulation? Right from the first birth it happens, but completed within a few minutes. Okay? The change can happen when the first breath is taken by the baby and behave like adult circulation within a maximum time of 1 minute. And what is transitional circulation and what factors affect it? The answer for that, this is the translation is referred to as the period immediately after birth when a newborn cardiovascular system shifts from the fetal pattern of circulation to neonatal pattern, which is almost like the adult pattern of circulation. And the reasons or factors during doing that are lung aeration. Adequate lung aeration is critical. So failure to clear lung fluid or initiate breathing. So if the child is born with apnea of the newborn because of maternal narcotic administration for labor analgesia or some cord around the neck, some fetal distress, then this may cause a delay in the transition from the fetal into the adult circulation. So it can result in persistent pulmonary hypertension and hinder the transition. The second is pulmonary vascular resistance. High PVR often due to lung disease or pulmonary hypoplasia, especially children with congenital diaphragmatic hernia. One lung on the hernia side may not have developed properly. So it may be a rudimentary lung. That may be the hypoplastic lung or acidosis. All these things can impede the PVR and prevent it from getting released, and that will continue to maintain the fetal circulation. Failure of SVR like blood volume and vasodilation, that also will affect the change from fetal to adult circulation. And fetal shunt closure, delayed closure of the ductus or foramen ovale can lead to persistent fetal circulation, causing oxygenation problem. That is, the right side blood will come and mix with the left side, causing hypoxemia that may result in hemodynamic instability also. And preterm babies are very prone for this because they have prolonged or difficult transition period due to immaturity of the lung, especially what is the thing that will be lacking in a preterm infant? The lungs.
Surfactant, sir.
Surfactant, fantastic. So that will affect the lung expansion and that will cause hypoxemia and that will maintain the pulmonary vasoconstrictor reflex, and that is the one which will still prevent this fetal circulation changing to adult circulation. And if you are doing some resuscitation effects with positive pressure ventilation, that also can have impact on the transitional. And maternal conditions like gestational diabetes or any puerperal sepsis or infections in the mother, it can also affect the with regard to anesthesia, can significantly impact the transitional circulation by affecting pulmonary and systemic vascular resistance. So when you do a neonatal surgery, make sure that you don't increase the pulmonary vascular resistance or induce the pulmonary hypoxic vasoconstrictor reflex by hypoxia, hypercarbia, or acidosis. Okay? So prevent factors like hypoxia, acidosis, hypothermia, and increase pulmonary vascular resistance, and that can increase more than the systemic vascular resistance, then the shunt will get reversed. So what is flip-flop circulation? What is the other name for that? This is the circulation changes at birth from the fetal to the adult type, but neonates are prone to revert to fetal circulation again with disastrous effects like severe hypoxemia. And this is also known as yo-yo circulation. Other name for the flip-flop circulation is also known as yo-yo circulation. Okay, so that is all about the